Hello and welcome to Healing Spaces, Design Dialogue for Mental Health, where we discuss the latest topics in behavioral and mental health design with industry experts and thought leaders. I'm your host of this podcast, Daniel White, and I'm principal of Pineapple, who are creators of mindfully designed furniture for challenging environments. I'm very pleased to be joined today by two industry experts to have a chat about assisting de-escalation through design. Specifically in the case of the EmPATH model, which stands for Emergency Psychiatric Assessment Treatment and Healing. We've got Dr. Scott Zeller, Vice President of Acute Psychiatry at Vacuity and also the creator of the EmPATH model. Also excited to have Virginia Pankey, who is Behavioral Health Practice Leader heading up planning and design of healthcare projects with a focus on behavioral health and acute care at the global design, architecture, engineering, and planning firm, HOK. If you'd like to read up more on our hosts, you'll find their bios on our website. So let's dive right in then. Dr. Zeller, could you explain exactly what the EmPATH model is?
Sure. Thank you for the very kind introduction. You already explained how the acronym stands for Emergency Psychiatric Assessment Treatment and Healing. And the idea for EmPATH was really to make sure that it had its own name, because there's a lot of other kind of things in what we might call the emergency psychiatry or crisis continuum, where there's things you call like crisis stabilization units or crisis receiving centers or all kinds of things. And there was a lot of names that seemed to mean a lot of different things. And we wanted to make sure that when people were talking about EmPATH units, that they knew exactly what they were talking about, which is an EmPATH unit is a hospital-based behavioral or emergency intervention unit that's, pretty much the equivalent of the medical ER for psychiatric emergencies, psychiatric acute urgent conditions. And we pay the same kind of dedicated and urgent attention to them that we would if somebody came in having a heart attack. And we really feel that, when people are going through a mental health emergency, they're suffering just like they were if they came in after a car accident or having chest pain or what have you. And they deserve that immediate attention to care. And the neat thing about EmPATH was that it was really, created to address a major problem we were seeing worldwide, which was a lot of people having a crisis or behavioral health emergency were coming to hospital emergency departments, asking for help. And the ERs were, the only thing we can really do is get you transferred to a psychiatric hospital. And over the past 20 years or so, the number of people coming in has gone up by over 400%. So there weren't so many beds in the psych hospital to transfer them to anymore, and it led to a lot of people backing up in emergency departments and staying there for long hours, sometimes days, sometimes, unfortunately, even weeks, and without any treatment at all. And what we knew from our work in emergency psychiatry is that if we initiate treatment and get people into a more therapeutic environment, something different than the emergency department, which we know in itself is kind of claustrophobic, scary, can make patient symptoms worse if you're having a behavioral health crisis, move them into a more therapeutic location, have them see a provider immediately, start treatment right away. The great majority of these folks are going to resolve almost immediately, compared to having to go to a psychiatric hospital and spending a week there. And so this is a win-win for the patients, it's a win-win for the hospital, it's a win-win for the whole system. And what we usually compare EmPATH to, like I said, it's a kind of a separate part of the ER or something that's nearby the ER where we quickly move people with behavioral emergencies. Kind of like if somebody came into the ER and said, I think I'm going to have a baby, the doc would look at you and say, okay, you are. Let's move you right over to labor and delivery. You're having a behavioral health emergency. Let's move you over to EmPATH. And it's based on the same idea that if you came into the ER, with a very typical presentation, shortness of breath, you have bad asthma attack. If we treated you like we do the typical psych patient, you came in struggling to breathe, we would say, oh, come on, we've got a place for you in the back hallway. We're going to have you sit tight while we look for an asthma hospital, and go ahead and keep breathing. We should have something for you in a day or so. And I mean, that sounds ridiculous. We can do the exact same kind of thing that we do for asthma patients, for psych patients, where, initiate oxygen, initiate nebulizer, and people are going to get better and go home. The exact same thing happens with psych patients. So it's a real game changer in doing now what, in a matter of hours, what we used to think took days or weeks and really just led to log jams in the system. Probably a longer answer than you were looking for.
So it's not just about providing a superior method, a more specialized method of care, but also about providing access to that specialist care as well. As you mentioned, that 400% upward trend. I have some statistics that in 2019, approximately just over 12%, 12.3% of emergency department visits here in America involve patients with mental health disorders. That equaled around 13.2 million ED visits for mental health related concerns during that period. There's a big number there. So yeah, that's fantastic. Thank you for your insight, Dr. Zeller.
I think those numbers is, Daniel, just really what drove it. People are saying they were feeling really bad because when you start having numbers like you were describing, some ERs, like half of their beds were filled with patients who were there for behavioral health psych reasons, and they were just waiting to be transferred for a bed. They weren't helping them. The patients were just getting worse, and it was just a terrible situation for everybody. So having an idea of doing something alternate in a more therapeutic environment, a more de-escalating environment, is really what the win is, and I think that's what we're talking about today.
Thank you. And Virginia, I'd like you to speak a little bit on in terms of the layout of an EmPATH unit and what the benefits of that are from your experience.
Yeah, certainly. The typical ED, most of us have either been to the emergency department for ourselves or with a loved one. And so that experience is very noisy, crowded, pretty fast-paced, tense environment, very institutional and clinical. A lot of times you just get pushed back and forth between waiting and triage, back to waiting, and then into an individual room where you might wait for yourself a very long time, and you might be getting lab tests and whatnot. And the staff is pulled in a lot of different directions. So the design for what we call in the FGI guidelines, the behavioral health crisis units, which is based on the EmPATH model. At the core of those units is what we call the multi-patient observation unit. So in the field, that's really known as the milieu. The patients are in that area, usually in a recliner. There's usually a table with some chairs where you can have some group conversation if you want. In that recliner, you can rest. The staff is usually in an open care environment that allows you to visualize all the patients. So if somebody has started to get a treatment, the staff can watch them and monitor them and see how they're doing. That open space allows for people to self-regulate, have some room for pacing. And we also have some support areas where the staff can utilize, get the medication, cleaning areas and stuff like that. But for the patient, right off of that milieu area is usually a calming room, so that if a patient finds that they want to have a quieter area, sit in a chair that might be a rocking chair or a beanbag chair, they can get comfortable and maybe adjust the light in there. So it's really physically a very different environment. And on top of that, the staff is specifically trained interdisciplinary staff who can really focus on the care of the behavioral health patients and their specific needs.
That's really insightful. Thank you, Virginia. So really the design of the unit is probably really key in what is probably very challenging. This is only short-term care. I noticed 75% of patients treated in EmPATH units stabilize and return to home within 24 hours. So that's a really short space of time that the caregiver has to assess the patient. What would be the main challenges in that, Dr. Zeller, that you would see within an EmPATH unit?
So, a really good point on what Virginia was saying about the difference in design. The typical ER is kind of claustrophobic and frightening, and it's not the ER's fault. I mean, they're designed for people coming in with car accidents and heart attacks, and that's the way they're designed is most efficient for that population. When we've got the behavioral health emergency population, having that open space, not feeling like they're being imprisoned or punished, it makes a whole difference. Having higher ceilings when possible, having ambient light from windows, all these kind of things really make a difference and make people feel more optimistic and calm rather than, I did something wrong and I'm being punished and I'm here in this situation. And I think to your question about, what's difficult to overcome, I think, unfortunately, as a society, historically, we've kind of identified people having psychiatric conditions as kind of criminal or othering, or these are people who are doing something wrong and we need to isolate them or get them out of the way or lock them up or what have you, just like if they were committing a crime. So some of the difficulty is that the patients who go through mental health crises have been through them. Most of them have maybe had this experience before, and they often are treated like they're prisoners or criminal offenders. And so they naturally go in with a wariness and concern that the staff are there as their adversaries, as their jailers, if you will. And so they're going to be there. They're not doing this to me. And that's where we see a lot of the things like agitation and aggression and violence that happens involving this population, because their mental state may be telling them, hey, these people are trying to hurt you. These people want to arrest you. These people are not your friends. They're your enemies. You need to defend yourself. That may be part of the illness. And so they're going to react in what you might expect a normal way to those kind of beliefs, which is I've got to fight or run. And so in a typical ER, that's not going to come out very well, and you're going to end up with security, and you may have a self-fulfilling prophecy where you get even more imprisoned or physically restrained and given kind of involuntary sedating medication, all kinds of bad things we choose to avoid. So I think that is a huge challenge in what people are expecting. So with EmPATH, the idea is let's make it a warm, welcoming, home-like environment with the design itself, and then let's train the staff to be engaging and collaborative and making sure that people feel like, no, you're safe. This is a place where we help. Nobody's going to get hurt here. This is going to be a good experience. And you're going through a tough day. We're going to help you get through it. And that's what we're here for. And there's no punishment. There's no judgment. This is just a place where people can relax and get better and get through what might be the worst day of their lives.
So, Dr. Zeller, when you're meeting with owner groups and care groups with what is going to be a new concept for them, what is the response like that you get to presenting this method of care?
Well, it's always fascinating because there's usually people who, what I'd say, get it right away, and their eyes light up, and they're like, "Wow, why haven't we been doing this all along? It makes so much sense. It's just so obvious." But they're not, sometimes they're the majority, sometimes they're the minority of the people. And then there's other folks who are there who are saying like, well, this will never work. And we can point to, well, this has been done in dozens of places around the United States. It's been done in multiple places around the world. And it's worked really well, and it's worked better than anybody could imagine. I mean, the same population who, if they were in the regular emergency department, 15 to 20% of them would end up in physical restraints. In an empath unit, it's 1 or 2 out of every 1,000 patients. I mean, that's a huge difference. And that's showing that with the environment, the attention, the approach changes a lot of things. It changes the dynamics, and it makes it so that we aren't worried about people becoming violent or agitated and having to do de-escalation. A lot of that's already being done by the environment itself and by the approach. But there's still people, and I think Virginia will have also heard this same thing, because I hear this a lot when I talk with architects who work in this field, which is there's always somebody, every hospital we discuss this, having an empath unit with, they will say, I don't think you've seen the kind of patients we have at our facility before. These are like really, really dangerous, high acuity patients. Nothing like this will never work with them. And I've probably now done consulting work at over 300 hospitals, and every single one of them said they had more violent, dangerous patients than I'd ever seen before. And the math doesn't quite work on that. They can't all have the most dangerous patients. The model was originally created in Oakland, California, which is considered one of the most dangerous cities in America, and indeed has one of the lowest police to individual ratios in America. So it's like even that much more dangerous because you don't have anyone to help. So that the idea that these very limited police force would be spending their time picking up non-acute patients just so that our ratios and our results look better is kind of facetious. So we were getting in Oakland, California, kind of the highest acuity of the highest acuity patients. And if it worked there, I think it will work in some of these other communities, despite what people are often always saying, which is, it's not possible. I think the one thing that's amazing when anybody goes to visit an empath unit in person, an operating one, is they always assume because there's, these are typically the highest acuity patients, the ones who would have been stuck in the ER waiting for an inpatient psychiatric bed, that these are going to be, agitated, aggressive, loud, combative, threatening individuals. But if you've ever been to an empath unit, the first thing you think is, wow, what a quiet place. It's like a library in here. It's so mellow. It's like the lobby of a hotel. It's comfortable. It's calming. And everybody seems to be doing okay here. And what a difference that is than what you might imagine of screaming, yelling, fighting, and a lot of people tied down in physical restraints and being medicated against their will. That's the game changer.
Perfect. Thank you for that. You mentioned metrics. What would be the key metrics of measuring success within an empath unit?
Well, I think the key one is, there's several ones that we usually look to. One is that usually the emergency department that is affiliated with the empath unit previously had patients who were there for psychiatric reasons and what we call boarding, where they're not doing anything, they're just holding on to them, waiting for a disposition, that boarding time could be an average of 10 to 60 hours. If you can imagine how unfortunate that is, that maybe like for 30, 40 hours, you're lying on your back, on a stretcher, looking up at the ceiling, you're getting no treatment, no intervention, you're already having a psychiatric emergency, worst day of your life, and you only get seen once every 8 hours for a little meal and a vital signs check, and you're just lying on your back with nothing else to do except maybe count all the number of holes in the ceiling or something like that. What a horrible way to kind of go through that experience. So we want to get people so that they never have to be boarding again. And we want to move them out of the ER as quickly as possible. So one of the first metrics we always work on is, once you've opened empath, how long are people now staying in the ER when they're there for a psychiatric emergency? Hopefully we get that down to a matter of minutes compared to the long hours, even days that it was before. Then the other big one is, out of this population, how many of them got admitted to inpatient psychiatric facilities? Once they go through empath instead, what's that percentage? And we usually see a dramatic change in that as well. And then there's some other cool things that we'd like to do metrics on, which is, one of the things when you were asking about what do the naysayers say, or the people have concerns when we move in, one of the questions is, well, usually these people would go off and they'd spend a week in a psychiatric hospital, and you're only keeping them for 15, 20 hours. Aren't a lot of them going to be coming back because you didn't treat them for a long enough time? Well, here's what the interesting thing is that we actually reduce the recidivism. The number of patients coming back to the ER within 30 days after going to EmPATH is far less, 25 to 50% less than the patients who'd gotten admitted to an inpatient unit. So that's amazing. And why is that? Maybe one of the reasons is that 60 to 90% of the ones who went through EmPATH are more likely to show up for their first outpatient mental health follow-up appointment after EmPATH than they were from being discharged from inpatient. So something's happening to change that cycle people always talk about, going to the ER, getting transferred to inpatient, getting discharged from inpatient, back to the ER again a few days later. Something's changing. I think it's the different approach, the treating people, with respect and saying that, we understand you're going through a tough time. This is a symptom of your illness. We're here to help, and we're going to do it in a very safe but comfortable and really optimistic environment.
Virginia, just to pop back on to the actual built design of an EmPATH unit, what would you say would be some of those key design influences if I were a designer working on an EmPATH unit that I should be aware of?
Sure. The key of space of openness and how that allows really respectful, non-threatening interaction between staff and patient. Also, the openness allows for that space to self-regulate if you're going to pace or maybe even do yoga. Different people use different methods for self-regulation. Having it be a soothing environment with soothing colors and kind of softer light rather than really harsh light, maybe even flickering when you would use the old time fluorescence. You want it to be a quiet environment, so you can use some materials with acoustical properties so that it stays a quiet environment. And then you need some what I'll call safe spaces, which might be like a little bench adjacent to a window where someone can, or maybe it's just a wall with someone with their back against the wall. So they're not worried about somebody coming up from behind, but they can see that open area. And if a staff member would approach them and keep a safe distance, could have what would be considered a very private conversation in that area. Having access to nature, whether it be just a view into nature or maybe the possibility of having access to a little courtyard would be great, so somebody could feel the air blowing against them. But that access to nature is known to kind of bring a relaxation to some people. And then a calming room so that a patient could go in, be able to kind of control the lighting in that area. Often those spaces have like a rocker that I mentioned before. And so have like even more kind of safer space if they need the quiet, and those open directly onto that milieu area.
So that's very good, Virginia. And some of those features that you mentioned are things that we can all relate to as humans for those superior design elements that allow for wellness of the mind. And we even see that happening right across the workplace. And that's fantastic. Thank you for that. One of the issues I love that you mentioned was acoustics. So acoustics are often a huge challenge in these environments. And I actually had that experience just yesterday when I was visiting a unit in Miami, and their day room where the patients hung out, watched TV, was right next to their nursing station. Well, it was actually across the corridor, and although they had glass paneling, it wasn't just an open space. The staff actually said that it's so loud in there that the patients can hardly hear the TV, so they turn the TV up to 100. It's loud. Maybe one person doesn't like the TV turned up to 100, but also patient confidentiality as well. They were saying that they could be discussing one patient about their medication plan, and other patients could hear that. So it's just really utilizing all of the expertise within this environment and having more interdisciplinary conversations with manufacturers, etc., to ensure that, we're not trying to retrofit something. We are designing for this particular continuum of care. And ultimately, also the staff, interestingly, it was a real pain point for the staff. So I know that staff retention is very difficult within these environments because of some of the situations they find themselves in, which could be avoided by this continuum of care. But what would you say as to the design of the unit really also being very important for staff?
So I think that that is a very key concern. And I think that having that interdisciplinary team really helps, and understanding that it is natural that there would be compassion fatigue amongst those staff members. So allowing this more healing environment really is helpful to both sides of the equations, the patients and the staffs, because it's not so hectic and loud. And we usually do have areas for the staff that are behind the care station where you might be allowed to just sit a moment and decompress. A lot of staff members that go into this field are incredibly empathetic, and we need to consider that. And they need to have space where they can see nature too, and take a moment to themselves to regroup if they're having a particularly difficult day.
One thing that to Virginia's point, Daniel, is that there was a wonderful feature article on EmPATH units a couple of summers ago in a magazine called The New Yorker, a pretty well-established, popular magazine, where they did a whole a center spread on EmPATH units, which was really amazing just in and of itself. But the author was a physician who is a doctor, works in a hospital in New York, not a psychiatrist, regular internal medicine doctor. But he had heard about EmPATH units, and so he flew out to see an EmPATH unit actually in Minnesota and did a whole story about it. And he had a small quote, which I thought just so hit the nail on the head of everything that we're talking about right now. And I just keep with me, and I'm paraphrasing here. I don't remember it exactly, but it was, we usually, he said that the revelation for him about EmPATH units was, we usually think of treatments in medicine as medications, procedures, interventions, surgeries, but the EmPATH unit showed me that the environment can be a treatment too. And that was really what so much of this is all about, is that we're trying to create an environment of healing where people can feel safe. They can feel like they're understood, that they're not being looked down upon, but they're actually given the opportunity to heal. And some of the things is that open space, the lighting, and other things are just simply, you can go and get yourself something to eat or drink or linens, and you don't have to ask somebody for that. You're allowing yourself to make choices about what happens next, which in itself is de-escalating. You never have to feel one down to somebody and beg them for them to get you a cup of water. You can take care of things yourself. That's part of de-escalation in and of itself.
Brilliant. Thank you, Dr. Zeller. And I was just thinking there, when any of us go to the hospital for whatever ailment we may have, we want to get healed as quickly as possible and get out of that environment, get out of that hospital, be released. So the environment really has to allow that. If I'm mentally unwell, if the environment's working against me, then that's going to be a very escalating factor.
Yeah, no, that's absolutely the case. And we've, so much of mental health has been misunderstood, and I think we've come a long way, but we still have such a long way to go. One of the things that we really try to teach when we're suggesting EmPATH, or even sometimes, I'll go and work with a hospital, and my team will work with a hospital, and maybe an EmPATH unit isn't the right solution for them based on their volumes or their available space or what have you. But they can change things. Maybe they can make part of their ER a little bit more welcoming. Maybe they can make it more open. But even more, we can help train the staff to look at things differently and be really, learn things like verbal de-escalation and calming techniques the same way they would learn how to do CPR. That would be considered a core competency among them, and that they would actually approach somebody having a behavioral emergency the same way they would with a heart attack. We've talked about this before, but not on this program, which is that when you're coming into the emergency room and you're having a heart attack, no nurse would ever yell at you saying, "Hey, what's your problem? Stop having chest pain. Stop having a heart attack. You need to stop that right now." But that same staff member might yell at a person having symptoms of their mental health emergency, which is leading them to respond. They're responding to auditory command hallucinations, or they're just really delirious or confused. And that same person will say, "Hey, you need to be quiet. You need to sit down. You need to shut up. You're going to be in trouble if you don't just go lie down or I'm calling security." It's kind of the same thing where they're not seeing it as what it is, which is a symptom of a medical condition. And just like we wouldn't try to yell at somebody to stop them from having pain from a broken arm or going through cardiac arrest, we shouldn't be yelling at them to stop having a mental health emergency. It's a medical condition. It's a disease state. We know how to help them, but that's just going to make it worse. So the de-escalation can be in the environment, but it also can be just getting the staff to understand these are people who are suffering. It's not a choice. They aren't doing it on purpose. They aren't bad people. They're regular people having bad symptoms of a bad disease state.
I think it really is that structural shift in how we think about the physical space and what's happening in the time that patient is in the behavioral health crisis. And so having them go to that right environment makes such a huge difference. And I think that there's a lot of talking and thinking about it, because people who haven't been in that crisis situation or maybe haven't seen someone they're close to or heard the anecdotes of someone who's actually gone through the situation think, well, I just want to be in a room by myself. Why would I want to do that? And as Scott mentioned earlier, that kind of feels like I'm in jail. I'm in a cell, even though it might just be a regular exam room as part of a hectic ED. People aren't paying attention to you, but you really need to get through this crisis and start being treated. And having the right environment and staff to do that can make all the difference in the world.
That's good, Virginia. And really what you're saying is, what I've heard from you and Dr. Zeller is that relationship between the patient and the staff member is actually a key de-escalation factor. So would there be any particular design features that you would see as, I know we've talked about that open space. I know recently I suggested having, movable seating products so the staff member could go up, sit beside the patient, but the chair wasn't necessarily there, that they were going to sit next to them. That'd be something that the patient may be invited so they could discuss the patient and their symptoms. But would there be any particular design features that you could draw attention to that would kind of encourage that staff and patient interaction?
I was going to say, I think that having spaces and elements within those spaces that allow the patient a sense of control and permits them. We have a little nourishment station, so you can get your own snacks, you can get your own water. So you're not going to a care station and saying, I want something to eat. They are in the middle of making a call, and then that can kind of lead to escalation. And if you just allow the patient to have some agency in, I can go get a blanket for myself. I can maybe control the internal blinds on the exterior windows so the sun isn't beating into my eyes. Really gives the patient a sense of respect that helps allow them to calm in addition to treatments that are being started.
And let me add on to that. One thing you kind of mentioned, Daniel, about the moving the chair up to like where the patient's sitting and kind of having that tete-a-tete, one-to-one discussion. One of the things that was going back to the question before is like, what did we get pushback, and what do, when people are starting to originally build these, do they not quite get at first? And they are so used to the idea of people being in individual rooms with a surgical table that's bolted to the floor and certain places where gases come out of the walls, and that's what a hospital room is, that they have a hard time getting away from that and thinking of, no, we just want an open space where people feel like Virginia was saying, like they have agency, they can decide what to do next, they can pick what's going on. And so I think what's nice is then you have furniture in an empath unit where if somebody wants to turn it around and have it face a different direction, that's easy to do, and that's fine. And if they want to pull a few chairs together so that they can do a little small, individual group therapy, they can do that too. And having, I think, flexibility is a huge thing on empath units, but also having the furnishings where that's easy to do, and maybe it's easy to turn things around and group different things together, and nobody's saying, no, this chair must go here, and that's where it is on this box on the design. No, if you've ever been to an empath unit, there's never a perfect spacing of the recliners or anything like that. They're all moved about, and people have moved in different ways, and that's good because they're figuring out what they want to do at that point in time, and they're engaging with other folks, and whatever that makes sense is great. At the same time, we do want those furnishings to be heavy so that people aren't picking them up for that one occasional patient who is having a difficult time with control and wants to use that as a weapon. So we want them to be easy to move around, but at the same time also heavy, that you're not just picking them up and using them in an inappropriate way. So I love the idea of furnishings being not fixed to the ground or bolted, but as part of the patient agency. And if, we always say when somebody comes on an empath unit, pick your recliner. Which one of these do you want to be hanging out with for the next few hours or so? You don't even have to stay there, but maybe that's the one you want to pick. And, if you want, you can get up and you move over to these tables. You can sit here by the window. We've got a little outdoor courtyard you can go into. All these things help people feel relaxed, feel calm, have their ability to make their own decisions about what happens next. All that is de-escalating, and all that helps people feel like they're engaged and they're collaborating rather than they want to fight the staff. The staff are now on the same team and they want to work together with them. And I think that's what leads to a lot of the things where after discharge, people are more willing to follow up because they're saying, hey, those people in the empath unit, they weren't so bad. They didn't seem like my enemies. They seem to really care about me and want to help me. Maybe I will take my meds. Maybe I will follow up with my appointment, and maybe this will help me. Anything that can change that for the better, I think we're doing a good job.
So what you said there is the built design really is immensely important in allowing patients to self-regulate and empowering them to be a part of their own healing journey. And it goes hand in glove with allowing staff to be successful in their rehabilitation plans for each patient. So this has been incredibly useful. I think we are going to have to wrap up soon. I've just got one other question I'm curious on in terms of future vision for empath units. How do you see the empath model evolving in the future? And are there plans to expand those principles into other areas of healthcare?
Oh, that's a great question. I think that given my area of expertise is psychiatry and behavioral health and mental health, that's really where my focus is on. And I think rather than branching out into other areas, because I don't want to presume to be an expert in things I don't know all that much about. But I think some of the ideas that we have at empath are universal. And one of them, the most compelling one is, our patients are people just like us, and they're going through a tough time. And just like we want to help any one of our family members or friends going through a tough time, we should have a natural kind of feeling like we want to help people in need. And it's kind of why we went into medicine in the first place, or nursing, or any of the other kind of healing arts that we're involved in, is we really want to do things that are going to make people feel better. And at the end of the day, we feel like we did something for another person that got them through a difficult situation. And so we know there's going to be more than 100 EmPATH units in the United States by 2027. I'd like to see that number keep going up exponentially, so that anybody who's coming to an emergency department, a few years from now, no matter what reason they're going there, is going to get the same high level of great care with people who are really invested in getting them through their tough day, whether they're there because they were in a car accident, or they're having a heart attack, or they're there for a mental health emergency.
I've had clients assume, well, EmPATH units are just for adults, and we really have a high percentage of adolescents coming into our emergency department. And that is not true. You can have an EmPATH unit for adolescents. It works very well. Scott could probably speak to that better than I can. But what that means architecturally is, a lot of times we share the care station and the back of house functions, and have one side be for adolescent patients and the other side be for adult patients. There are even some designs that have some kind of flexible nature to them, so that if you're having a really high census with adolescents, that you might be able to move that, and then have a smaller set of adults. And I think there's lots of ways we might be able to manage that in the future, and open to lots of possibilities as we move forward.
Yeah, I'm so glad that Virginia brought that up, because it's one of the hottest things in EmPATH right now is the pediatric and adolescent populations, and facilities building the capability to see both of them, but without having to commingle, which we recommend against. And so if we can accommodate all age groups in an EmPATH unit, and if that means that we have to come up with some innovative ways to make sure that we're not having a 60-year-old person and a 9-year-old in the same space, we can do that. But that's where I rely on the architectural and design geniuses like yourselves, and I'll just be a doctor.
So it's been a very interesting discussion on what's a very important topic in our field of mutually working hard to improve this type of care that someone in crisis has access to. I'd like to thank both Virginia and Dr. Zeller for your insights, thoughtful contributions, and hopefully we'll see you back on the podcast again soon.
Well, thanks for having me. This was a great discussion. And I think all of us need to work together to continue to improve the environments of care for patients that have behavioral health issues.
Yeah, couldn't agree more. And one of the greatest things, I think, for me in the last few years is meeting so many people in the design and architecture world who share my goal of just making things better for this population. And it's been really refreshing and energizing.
Well, thank you both for what's been a very interesting discussion. To our listeners, thank you for joining us. Do make sure to follow our podcast so you don't miss the next exciting episode. Until next time.